Assalamu alaikum everyone. Welcome to another video by Dr. Nerd. I hope everyone is staying safe at home. Today we're going to be talking about the pericardium. Now, what is the pericardium? The pericardium is a layer of fibroserous tissue surrounding the heart at the root of the great vessels. We're going to go into detail on the definition of the words fibroserous in a bit. The function of the pericardium is that it protects the heart from excessive motion and it also lubricates the surface of the heart. So here we have the muscular portion of the heart, the myocardium, and as it's beating, it's moving inside the chest. The pericardium, for one, it makes sure this movement is smooth and there's no friction, and it makes sure that the heart doesn't move too much within the chest. So we can split the pericardium into two main portions. There's the fibrous pericardium and there's the serous pericardium. And each one is kind of named on its function. So the fibrous pericardium is made up of fibrous tissue. It's tough tissue, think like a tendon or a ligament. It forms the outer layer of the pericardium, and it's there for protection. It's really thick. The serous pericardium, from its name, it secretes a serous fluid. It's deeper than the fibrous pericardium. It secretes the fluid that makes the movement of the heart frictionless. We can split the serous pericardium into two further parts. Parietal pericardium, which is the more superficial part, which lines the inner, which forms the inner lining of the fibrous pericardium. The visceral pericardium makes up the outer lining of the heart. So we have the fibrous pericardium to be over here on the outside of the heart, lining the inside to be the parietal pericardium, and lining the heart to be the visceral pericardium. There's going to be a better diagram soon. So here's a simplified diagram. Where we see the serous pericardium is this part on the inside of the pericardium. So we have one that's lining the heart and one that's lining the inside of the fibrous pericardium. And this outside layer would be the fibrous pericardium. The way the pericardium covers your heart is similar to the way that a balloon would cover your fist if you were to punch it. So you would put your fist through the balloon, there would be this part of rubber which is kind of around your fist, and since the balloon has a cavity, there would also be an outer part. This is a more detailed anatomical diagram. So as you can see in more detail, this pink part is the serous pericardium. The part that's on the heart is called the visceral. The part on the fibrous pericardium is called the parietal, and the white part is the fibrous pericardium. Fibrous pericardium, if you go here inferiorly, it attaches to a tendon on the diaphragm called the central tendon. So it's the central tendon of the diaphragm. The attachment to the central tendon of the diaphragm also prevents the heart from excessive motion. So we've discussed how there's two layers of pericardium. There's the fibrous and the serous, and between the serous there's the visceral and the parietal. And between the visceral and parietal serous pericardium, we have something called the pericardial cavity. Pericardial cavity is a potential space. Potential space means that the space is practically non-existent, like the two surfaces are basically touching each other. But if you were to fill the space with fluid, then you would have a bigger space. So it's potentially can form a space. So this surface, and it's in an animated picture, you can see that there is a space, but in real life, these two surfaces, the parietal and visceral serous pericardium, can be touching, and if you put fluid inside, then they would be separated. This is why we call it a potential space. The pericardial cavity is filled with a thin fluid. It's a thin serous fluid, again, because it's lined by the serous pericardium, and it enables the heart to move and beat without any friction. Blood supply of the pericardium is pretty simple. It's the pericardiophrenic artery. It's a branch of the internal thoracic artery. Pericardio here is obviously referring to the pericardium, and phrenic is referring to the diaphragm. So it's an artery that supplies the pericardium and the diaphragm. Since we have a pericardiophrenic artery, we should have a pericardiophrenic vein. Again, pericardium for pericardium, phrenic for the diaphragm, but the nerve is only called the phrenic nerve because it mainly supplies the diaphragm. Pain that is sent by the phrenic nerve, some can refer to the shoulder. Pain refers to the shoulder. So if you have any damage or inflammation of the pericardium, this would lead to pain in the chest because the pericardium is in the chest, and because of the phrenic nerve, some of it might refer to the shoulder. So you have chest pain with some referral to the shoulder, and this is a very similar case to myocardial infarction, where you have severe chest pain, which refers to the shoulder. So moving on to pericardial diseases, there's three topics that we're going to talk about: pericarditis, pericardial effusion and tamponade, and constrictive pericarditis. These two would be considered one entity. Pericarditis is inflammation of the pericardium. So From the word, you can see pericard, which refers to pericardium, and itis means inflammation, so it's inflammation of the pericardium. It's the most common pericardial disease. It leads to chest pain, and the signs and symptoms can sometimes be similar to myocardial infarction, so it has to be distinguished from an MI. So the most important symptom by far that you have to know for pericarditis is that it presents with positional chest pain. Here it's highlighted in red, positional chest pain. Positional chest pain means that if a patient is in a certain position, the pain will get worse, and if they're in a different position, the pain will get better. So when the patient is supine, the pain is worse when the patient is supine, and the pain gets better if they lean forward. The pain is also pleuritic. Pleuritic comes from the word pleura, because when you take a deep breath, you distend the pleura, and this increases the pain in pericarditis. And since this is an inflammatory condition, in inflammation we have activation of the immune system. You may also have the patient with fever and an elevated level of white blood cells. So most cases of pericarditis are idiopathic. Idiopathic is a fancy way of saying we don't know what the cause is. The most common known cause, though, is a viral infection. Pericarditis usually falls an upper respiratory tract infection, and the cause of the upper respiratory tract infection would often be Coxsackie virus. Another type of infection that can cause pericarditis is bacterial infection. Bacteria can spread from the lungs when a person has pneumonia, and from the lungs you can also have spread of tuberculosis. And when someone is having surgery, you're obviously opening the chest to the outside environment, and so bacteria can come in from the outside environment and infect the pericardium. Fungal infections are also possible. Uremia is the most common systemic disease that can cause pericarditis. Systemic disease means it affects the whole body. Autoimmune diseases like systemic lupus erythematosus and rheumatoid arthritis. Common characteristic in some of these diseases is inflammation of the serosa, like the pericardium and the pleura. Neoplasm or cancer can also metastasize to the pericardium and lead to pericarditis. And a high yield point here to know is that there are two types of pericarditis that can happen following a myocardial infarction. You have fibrinous pericarditis and autoimmune pericarditis. So if you have a patient with a myocardial infarction, presents within days with the symptoms of pericarditis. So 3 days ago, a man in his 50s had a heart attack. Now he's presenting with positional chest pain, pleuritic chest pain, and fever. Say, if this is within days, I would say this is fibrinous pericarditis. If they come in within weeks, so for example 2 to 3 weeks later, this would be an autoimmune pericarditis. So the immune system itself is attacking the pericardium. So here are some of the signs that one of the signs we can see for pericarditis is in ECG changes. So again, we're going to go back to the similarities between pericarditis and myocardial infarction. In lead 1 here, we can see an ST elevation. We can also see one in lead 2. You can see ST elevations in leads V2, V3, V4, and a little bit in V5. You also have ST elevations, and in myocardial infarction, you also have an ST elevation in some other diseases. But what distinguishes pericarditis from all these other diseases is that you have something called diffuse ST elevation. The classic case with pericarditis is that you would have ST elevations in all of the leads, so 1, 2, 3, AVL, AVR, AVF, all the others. And if you see ST elevation in all the leads plus the symptoms, you should say this is definitely pericarditis. Another ECG change can happen is something called PR segment depression. So when we say a segment in ECG, we mean the distance between a wave and another wave. So the distance between the P wave and the R wave, there's a segment, and this segment would have like a downward bulging, like here. Here you can see it, here you can see it, here you can see it a little bit. So this is called PR segment depression. It's another ECG sign in pericarditis, and this slide sort of sums up the ECG changes. You have an ST elevation and a PR segment depression. An auscultation, you hear something called a friction rub. Friction rub is a scratchy sound that happens while you're auscultating the chest. Hopefully the sounds will be included in the description so you can listen to them. Treatment of pericarditis is very simple. It's an inflammatory condition, so we want drugs that can inhibit inflammation. NSAIDs are sort of first line. NSAIDs that include aspirin, ibuprofen, naproxen. Colchicine is a drug that inhibits the action of neutrophils. It's also useful in pericarditis. It's often used in combination with NSAIDs actually. And if someone has a contraindication to NSAIDs, or they can't use NSAIDs because of another disease they have, or because of they used NSAIDs before and the NSAIDs didn't cure them, we can also use corticosteroids. Corticosteroids are also useful in treatment. Pericarditis is usually self-limiting, so often a patient will get pericarditis and then it'll just go away on its own. Some of the complications that can happen though from pericarditis are pericardial effusion and constrictive pericarditis, which are the other two diseases that we're going to talk about. Pericarditis may recur, so almost a quarter of the cases, the patients will be cured, they'll have no symptoms anymore, and then a few months later, the symptoms will come back and they'll be diagnosed with pericarditis. So now we're done with pericarditis, we're moving on to pericardial effusion and pericardial tamponade. So both of these terms sort of have the same meaning, and let me explain this. So the pericardial cavity that we explained before normally has 20 to 50 cubic centimeters of fluid. This is a very small amount of fluid, and any increase in the amount of fluid may compress the heart chambers and lead to decreased cardiac output. So again, the pericardium surrounds the heart, and the pericardium within it has a cavity, and if the cavity gets filled and there's a high pressure in it due to fluid, this can compress the heart, and so the chambers can't fill up with as much blood as they used to, and this will decrease cardiac output. Pericardial effusion can be acute or chronic, and here the acute form of the disease would actually be much worse than the chronic. So to explain this, we have to see that in the chronic pericardial effusion, there's a chance for the pericardium to stretch. It allows the pericardium to stretch so symptoms are not as severe. So if you have a few cc's increase of fluid over time, pericardium, it takes time to stretch, so over a long time it will stretch. Whereas in acute, even if you have a small amount of fluid that goes into the pericardial cavity very suddenly, pericardium doesn't have a chance to stretch, and so the heart is compressed very quickly. This can lead to catastrophic outcomes. So even a small amount of fluid here is dangerous, whereas in chronic, a large amount of fluid may be present in the pericardial cavity without any serious problems. Causes of pericardial effusion and tamponade include trauma to the pericardial cavity, bleeding into the pericardial cavity, so for example from an aortic dissection or for bleeding from the heart, from the arteries that supply the pericardium. Cancer, which we said can cause pericarditis, can actually also cause edema into the pericardial cavity. In fact, any cause of pericarditis, because inflammation leads to edema, and edema is extravasation of fluid, so any cause of pericarditis automatically would also be a cause of pericardial effusion. Hemopericardium is a type of pericardial tamponade in which there is a rapid accumulation of blood into the pericardial cavity. Here we see a very large blood clot surrounding the heart where the pericardial cavity would have been. It's often caused by diseases like aortic dissection and ventricular rupture. These will lead to a very large input of blood into the pericardial cavity. And this is an acute form of pericarditis, so obviously the complications will be severe. Symptoms of pericardial effusion and tamponade. So the pericardial cavity, which used to be a potential space, used to be very small, now it's filled with fluid, and now it's really big. So this would increase the distance between the heart and the chest wall. So when you listen on auscultation, you hear distant heart sounds. The elevation of the pressure inside the cardiac chambers, including the left atrium, will lead to pulmonary edema. Pulmonary edema will lead to dyspnea. Patients with pericardial effusion also have something called Pulsus Paradoxis, which we're going to elaborate on in a bit. They're going to have elevated jugular venous pressure. Severe cases, the patient might have hypotension because of the decrease in cardiac output. And if it's a chronic cause of pericardial effusion and the fluid is slowly collecting over time, they may, for a very long time, be asymptomatic. Pulsus Paradoxis. Okay, so to understand Pulsus Paradoxis, you need to understand that normally, when you take a deep breath, your blood pressure goes down by a little bit, but only a little bit. In patients with pericardial effusion and a number of other causes of diseases, the drop in blood pressure in this case is very severe. It's greater than 10 millimeters of mercury. This is caused by compression of the left ventricle. This causes drop in the blood pressure. Severe Pulsus Paradoxis in severe cases of pericardial effusion or other diseases may lead to severe Pulsus Paradoxis, which causes an absent pulse, may cause an absent pulse. Pulsus Paradoxis is also present in severe respiratory conditions such as severe asthma or emphysema. This is a chest X-ray showing pericardial effusion, although this is not a specific image. So if you see this image on X-ray, don't immediately say this is pericardial effusion or tamponade. Other diseases can cause this shape to be shown on X-ray, which is an enlarged heart, but this does point to the conclusion that the heart is enlarged for one reason or another. CT scan. So this would be more specific, where you can see here, you can clearly see the chambers of the heart. This white part is the blood inside the heart, and this gray area all around the heart, this is all fluid. So this is much more fluid than is normally present inside the heart. Another investigation you can do is the one down here. This is called an echocardiogram, which is basically it's an ultrasound of the heart. So on ultrasound, fluid is black, If you remember from your course last year, fluid is black, so you can see this black area around the heart. This is all fluid. This would be the apex of the heart, ventricular walls, blood inside the heart, and this is all fluid. Just like in pericarditis, in pericardial effusion, we can have ECG findings. We have non-specific ones like sinus tachycardia, which is just high heart rate, and we can have a low voltage QRS and something called electric alternates. So here, the QRS complex is much weaker, it's much smaller than you would see on a normal ECG. This is why we say it's a weak voltage QRS complex, and the heart rate here is very fast, so this is what we call sinus tachycardia. All the problems that we see in pericardial effusion are caused by the accumulation of fluid. And so the logical treatment would be to remove that fluid. And so the treatment for pericardial effusion, tamponade, are drainage of the pericardial cavity or pericardiocentesis. Moving on to the last condition, we're going to talk about constrictive pericarditis. It's called constrictive because there's a layer of fibrous scarring and calcification of the pericardium which constricts the chambers of the heart. So it's a fibrous scarring with calcification, so any cause of damage to the pericardium logically can lead to chronic damage, which can lead to scarring. So some of the causes are pericarditis, like you mentioned before. One of the complications is constrictive pericarditis. Radiation, so for example, a patient receiving cancer treatment by radiation, or someone who works in an X-ray lab who doesn't use their protective equipment, they might get radiation to the chest and that might damage the pericardium. Surgery can lead to scars in the skin or anywhere you do surgery, so it can logically lead to scars in the pericardium. And infections of any type, viral, fungal, tuberculosis, whatever, can also lead to scarring. The image on the left here, A, is showing a very thick, this white thick area. This is the calcified, scarred area of the pericardium, which is constricting the heart chambers. So to understand the symptoms of constrictive pericarditis, you have to understand that the right heart is affected more than the left heart. Constriction of the right heart will lead to a decrease in cardiac output of the right heart, and that will thus lead to symptoms of right-sided heart failure. Symptoms such as edema, elevated jugular venous pressure, and can even lead to swelling of the liver, which may eventually lead to cirrhosis because of liver edema. Pulsus paradoxis is a sign that may be seen in constrictive pericarditis. It's rare though, and it's mostly seen in tamponade. Dyspnea is also something that can be seen, and a rare auscultation sign is pericardial knock. Another sign that can be seen in constrictive pericarditis is elevation of jugular venous, is something called Kussmaul's sign. Kussmaul's sign is elevation of jugular venous pressure while inspiring. So normally, jugular venous pressure, or all venous pressure actually, decreases when you inhale, because when you inhale, you increase venous return to the heart. What happens in constrictive pericarditis is that the right ventricle is constricted, and so it can't accept or accommodate the increased inflow of blood. So a lot of that blood actually stays in the venous system. This leads to an increase in pressure in all of the veins, including the jugular veins, so you have elevated JVP. Another sign that you can see in constrictive pericarditis is called the dip and plateau sign. So I want you to imagine here, this is a graph that's measuring the pressure inside the right ventricle. The yellow line is sort of the normal. So during diastole, you would have relaxation of the heart chambers, so the pressure would go very high, very low. And then during systole, or further in diastole, it would start filling, and then during systole, the pressure would go way back up again. In constrictive pericarditis, remember that the right heart is constricted, and so you can't, the heart can't relax as much since there's a pressure outside, so the relaxation doesn't go fully. And when the heart is filling, it can't fill completely, again, due to the constriction that's around it, so the pressure in it plateaus a bit until the heart chambers start to contract and the pressure goes back up again. This can also sometimes be called square root sign, because if you look at the pressure curve that's going down and then plateauing, it kind of looks like a square root. The diagnosis of constrictive pericarditis can be confirmed by an X-ray, which here you see the heart, and around the heart you see this semicircle, very bright white calcification. It can also be confirmed by a CT scan. So these lines here, this line here is white, here is white, here is white, here is white. These white things are calcifications. So like pericardial effusion and tamponade, where the problems were caused by fluid, here it's caused by the scarred, calcified pericardium. So the treatment for constrictive pericarditis would be surgical removal of the pericardium, which is also called pericardectomy. And that concludes the video on pericardium.